Good afternoon. It's my pleasure to announce Dr. Aguirre and Ms. Clifford. For more than 50 years, the Crohn's and Colitis Foundation has been a leader in inflammatory bowel disease in research and clinical practice. More than 10 million people worldwide live with IBD and often suffer in silence, struggling with an invisible disease. The Crohn's and Colitis Foundation is dedicated to changing that, improving the lives of children and adults living with IBD. Foundation offers educational workshops and programs for healthcare professionals, publishes 2 scientific journals to assist with health professionals in keeping pace with new research and treatment. Foundation also supports patients and caregivers through advocacy, nutrition, education, and more. We're pleased to welcome Dr. Jose Aguirre, Assistant Professor of Gastroenterology at the Department of Internal Medicine at the University of Texas Medical Branch in Galveston. Dr. Aguirre earned his Bachelor of Science degree in biology in 2004 from St. Mary's University in San Antonio. After completing predoctoral research training at Mass General, he obtained his medical degree in 2013 at the UTMB Center for School of Medicine in San Antonio. While at UTMB Galveston, he obtained a master's degree in medical sciences in 2017 and completed the American Board of Internal Medicine Physician Scientist Subspecialty Research Pathway in 2019. Dr. Aguirre is a member of the Crohn's and Colitis Foundation South Texas chapter. He's a medical advisory on the medical advisory committee and serves as co-chair of the patient education subcommittee. Dr. Aguirre is joined by Ms. Carrie Clifford, who serves as manager of volunteer engagement at the Crohn's and Colitis Foundation Southern Texas chapter. Please join me in welcoming Dr. Jose Aguirre and Ms. Carrie Clifford to the Tilman J. Fertitta Family College of Medicine Grand Rounds.
Hello, everyone. I'd like to take the opportunity to thank everyone for inviting me to your grand rounds today. Today, I'll be talking about preventative care in inflammatory bowel disease. I have no disclosures for today. So our plan is we will review the epidemiology, etiology, natural history, and prognosis of IBD. We'll also seek to identify the roles of providers and the importance of multidisciplinary care. And lastly, discuss vaccinations, screening, and management of extraintestinal manifestations, which will reveal the inherent risk to this patient population. Inflammatory bowel disease is a chronic, relapsing, immune-mediated inflammatory condition affecting the gastrointestinal tract. It also can affect it can also have extraintestinal manifestations. Incidence is rising both in the developing as well as the developed world, and approximately 1 million are affected across the United States and Europe. There is a bimodal distribution and about an approximate equal preponderance between the sexes. Predominant age of onset is from 15 to 30 years of age. Currently, there is no cure, and this is largely due to the incomplete understanding of the pathogenesis behind this disease. The pathogenesis of IBD remains unknown. However, the general consensus implicates the interaction of environmental factors, both the patient's genetics as well as epigenetics, those interactions with the gut microbiota, and all within a dysregulated immune system. The mainstay of approach to treatment thus far has been the suppression of inflammatory cells or cytokines, which unfortunately have not shown to be curative. The current hypothesis is that excessive T-cell mediated immune responses to specific components in the intestinal microbiota cause tissue damage. This occurs in genetically susceptible hosts. It is triggered by additional environmental factors or the gut microbiota. And overall, this leads to a dysregulated or constitutive activation of the enteric immune response, leading to both acute and chronic inflammation and development of the pathological features of mucosal damage. The innate immune response is also altered in IBD patients. So our innate immunity, our first responders, include cells like monocytes, macrophages, as well as bacterial sensor detectors like dendritic cells. Both of these cell types make pro-inflammatory cytokines and activate the adaptive immune response. The adaptive immune response, or a specific immune response, is regulated mainly by T lymphocytes within this disease. These T lymphocytes function to regulate the overall adaptive immune response. They proliferate with more pro-inflammatory cytokines, create cell adhesion molecules for recruitment of additional inflammatory proteins, and also proliferate with more lymphocyte activation and proliferation. Thus, together, the innate immune cells and adaptive immune cells regulate the inflammatory response. This schematic highlights the innate immune cells. Here's looking at macrophages and dendritic cells within the intestinal mucosa or the lamina propria, and they sample commensal bacteria and initiate the inflammatory response with cytokine production. This would then lead to activation of T cells, which further proliferate many inflammatory cytokines or inflammatory markers. In inflammatory bowel disease, there's a failed regulation of these T cells or overactivity of them, leading to excessive tissue damage. Many of the medications targeting inflammatory cells or cell trafficking molecules or cytokines try to limit this inflammatory response. This schematic highlights the chronic and relapsing nature of the disease and its impact on digestive organs. Inflammation starts in the preclinical setting at disease onset and occurs simultaneously with tissue damage. Although flares, which are these little peaks here, followed by areas of remission, there is progressive tissue damage, which can lead to things like strictures, fistulas, abscesses, and ultimately surgery for a vast majority of our patients, thus conferring a significant morbidity from this disease. The initial presentation of inflammatory bowel disease, there's two entities, both Crohn's disease and ulcerative colitis, but we'll collectively refer to them as IBD today. Crohn's disease can present typically with diarrhea, abdominal pain, whereas ulcerative colitis presents more with bleeding, urgency, and tenesmus. Initial presentations can be variable. However, both diseases cause significant morbidity. This is experienced by anxiety, depression, malnutrition, ultimately surgery for many patients, and impaired social or career progression. So basically our quality of life. Long-standing disease is also associated with risks of dysplasia or colorectal cancer. For prognosis, inflammatory bowel disease can have a very highly variable disease course. Within the first year of diagnosis, relapse rates approach approximately 50%. Approximately 10% of patients will become debilitated by their disease, and 70% of them will need surgery in 20 years or at a rate of 3 to 5% per year. Many of the complications of inflammatory bowel disease include fistula formation, strictures, abscesses, as well as many extraintestinal manifestations. Some more severe complications can include gastrointestinal bleeding, colonic perforation, as well as toxic megacolon. Now, we are currently living in what's called the age of biologics, where a lot of our therapies are targeting specifically targeting a lot of the cytokines we discussed earlier. And this has improved our ability to control intestinal inflammation. However, surgical rates have not yet improved. So to limit the morbidity of this non-curable disease, it's important to understand the goals of treatment outlined here. First, we want to sustain and maintain a durable period of steroid-free remission. Initially, our first targets were just clinical remission, but over time, more studies and more preventative care, we're finding that endoscopic healing is our emerging goal, the goal to have mucosal healing. So this schematic highlights a traditional approach to treatments based on the severity of disease. The mainstay of mild disease is treated with 5 ASA drugs, the aminosalicylates, as well as a clonic specific steroid. Going in the classic step-up approach in moderate disease, we use medications like immunomodulators for the thiopurines, methotrexate, as well as prednisone. And in severe disease, where we use more of our advanced therapeutics, so this includes anti-TNF therapy, our biologics, our small molecule inhibitors, rescue cyclosporin, and ultimately surgery. At all stages of treatment, immune-suppressing medications may be used, which add additional risk to our patients. Now, in moderate to severe disease, there's a shift towards a top-down approach. Here, advanced therapies or thiopurine, plus or minus their thiopurines and steroids used early in the disease course, and this is to hopefully alter patients' ultimate disease course. And surgery be used later in their disease. Now, whether using a bottom-up or top-down approach, IBD patients are exposed to immune-suppressing medications. The first goal of treatment, again, is to induce and maintain remission. As outlined earlier, the 5 ASA drugs, immune modifying drugs, and advanced therapies are used both in the induction of remission as well as in the maintenance of remission. As highlighted here on the left, corticosteroids are at times used in the induction phase, but should never be used for long-term therapy and never a maintenance therapy for patients with IBD. So in summary, IBD patients are a high-risk group due to variable disease courses with progressive tissue damage and dysregulated immune responses who are exposed to immune suppressing medications. Thus, preventative care plays a crucial role in patient outcomes. So who is responsible for the preventative care in the patient with IBD? Well, let's find out. Unfortunately, patients with inflammatory bowel disease receive reduced preventative care services compared to the general population, which is surprising considering they're such a high-risk group. Many patients, in fact, consider their gastroenterologist as their primary care provider, especially in the younger populations who've never really established care with the PCP. Regardless of the primary provider, the gastroenterologist should specifically inform the healthcare team of special needs, including vaccinations, treatment-specific screenings, as well as clearly outlining the at least tentative or thought out plan for the use of immunomodulators or advanced therapies. So for vaccinations, IBD patients receive vaccinations at a lower rate than the general population. Again, this is unfortunate since they are at increased risk for preventable infections. And this is due in part to their not only the dysregulated immune system, but also the fact that they're exposed to immune suppressing medications. So who's responsible for the vaccinations? Well, studies which surveyed both physician attitudes and knowledge-based in vaccinations provided some insight into the challenges facing the reduced vaccination rates in IBD. When asked the gastroenterology group, approximately 80% of the gastroenterologists say the primary care provider is responsible for vaccinations. Within the same group, approximately 25% of these gastroenterologists gave live vaccines to immunocompromised patients. Again, this is strictly on a survey, and approximately 30% withheld non-live vaccines to immunocompetent patients. When asking the general practitioner, approximately only 30% feel comfortable managing the preventative services or vaccinations of an IBD patient. So this gap is something that needs to be addressed. So communication is key to providing the multidisciplinary care that IBD patients need. A vaccination plan should be communicated both with patients as well as between providers and documented in medical records. It is of the utmost importance to start early with vaccinations. Our patients with IBD will likely need immunosuppressive medications or advanced therapeutics, and they possibly have reduced responses to vaccinations once those therapies have started. It's also important to note that treatment of active disease should not be delayed with the administration of vaccinations. Lastly, it's also important to remember that vaccinations do not cause relapses or worsen disease, which is a common question that patients have. All IBD patients, regardless of their degree of immunosuppression, should receive inactivated vaccinations. And this is all non-live vaccines that we recommend are flu, pneumonia, hepatitis, HPV, and tetanus and pertussis. These vaccinations are safe for the household context to receive as well. We recommend annual intramuscular inactivated influenza vaccinations. IBD patients have a higher rate of influenza infections compared to patients without IBD. Many patients are on immune suppressive therapies and as well also have higher rates of co-infection with pneumonias. Household contacts of immune suppressed patients should also receive the inactivated vaccines. And of course, this is a theoretical, not a, there's no yet confirmed transmission for family members who've had live vaccinations, but we still recommend that they receive the inactive forms. For pneumococcal vaccination, IBD patients compared to age-matched non-IBD patients have an increased risk of pneumonia vaccinations. This risk is also increased if their patients are on biologics, thiopurines, or corticosteroids. And we prefer administration of these prior to combination therapy. All IBD patients should receive at least one pneumonia vaccination, while if we're on combined therapies, we need at least 2. Hepatitis vaccinations for A and B are also non-live. Hepatitis B reactivation has been reported in immune suppressed IBD patients, so it's very important to test patients for either hepatitis B exposure or previous infection prior to starting any anti-TNF therapies. Hepatitis A and B vaccinations also have been shown to have decreased efficacy in IBD patients, so it's important to check titers in our immunocompromised patients to ensure that they maintain their vaccination status. So which of the following statements is true regarding vaccinations and IBD? Anybody like to take a shot?
It's A, right?
Sorry?
Is it A?
That's correct, A. So non-live vaccinations are recommended for IBD patients, including those on dual therapy. That would be a biologic and a thiopurine. So for a quick case, we have a 60-year-old male who has 80 kilograms with extensive ulcerative colitis, which is well controlled. He is both in clinical and histologic remission over the past 4 years and maintained on daily 2.4 grams of the 5-ASA drug mesalamine and 150 milligrams of azathioprine. He was exposed to chickenpox as a child and is interested in the shingles vaccine. What is the next step? So for zoster vaccination, we should consider zoster vaccination for all IBD patients over the age of 50 or even younger if patients are taking a JAK inhibitor. There's an increased risk of zoster compared to non-IBD controls, and this is regardless of the disease duration. It may be associated with their immunosuppressive medications and may occur at an earlier age in IBD patients. It is okay to immunize household contacts, but if they do develop a rash, contact precautions should be maintained between the patient and the family member. Here, low-dose immunosuppressed patients may be vaccinated. Now, to simplify this, Shingrix is a non-live zoster vaccination, which can be used in immunocompromised patients and doesn't require titers or the risks of development of disease. So in this case, we proceed, and in our case, we proceed with vaccination. Patient is on a low-dose immunosuppressive medication, so methotrexate, azathioprine, or 6-mercaptopurine at these levels of mg per kilogram would be considered low-dose immunosuppression and can receive the vaccination. Our next case, we have a 30-year-old female diagnosed with fistulizing Crohn's disease. She's currently stable, and we're planning for biologic therapy. It's unclear if she's had a history of exposure to chickenpox. It's unclear if she had a varicella vaccination, and her tuberculosis and hepatitis B surface antigen are negative. What is the next step for varicella vaccination? So in this case, what we want to do is we want to make sure that we assess for exposure and vaccinate treatment-naive IBD patients prior to the initiation of their immunosuppressive therapies. Varicella is contraindicated in the 1 to 3 months prior to initiation of biologics, so some planning does need to be done here. It may be considered in low-dose immunosuppressed patients, and again, it's okay to immunize households. And if a rash does develop, then contact precautions again are utilized. For our patient here, we can obtain IgG titers. Again, we're trying to assess their exposure for varicella, and then we can vaccinate appropriately. This next slide is a nice summary slide for some of the live vaccinations. When we're looking at MMR and varicella, if we don't have a known vaccination history or an unclear vaccination history, then we would check titers prior to initiation of the vaccination. If patients are already on immune suppressed medications, then it depends on which type of medications and what dosage, if they can receive the varicella and zoster. Vaccinations for household contacts is allowed for all 3 of these vaccinations, but again, if a rash occurs, then contact precautions should be offered. A reminder, we like to administer all these vaccinations at least 6 weeks prior to starting the immunosuppressive therapy or 3 months after stopping an immunosuppressive therapy. We can't talk about vaccines without at least discussing the COVID vaccinations. COVID vaccinations are safe, effective, and recommended for all IBD patients. And we have a few different trials now that have added to this initial data. But a lot of the information comes from Pfizer as well as Moderna, where they looked at IBD patients who have received either anti-integrin, CNF therapy, IL-1223 inhibitors, or steroids. And they do show that the vaccination is effective. And a much larger cohort of patients, approximately 2,900 of them on either immunomodulators or advanced therapies. They looked at adverse events were similar between IBD groups and the control groups. COVID infections following vaccinations were occurring at similar rates, and there were no changes in steroid prescriptions for the vaccinated or unvaccinated patients. Our take-home message for vaccinations is that our IBD patients are at higher risk for preventable infections. We have lower rates of vaccinations within the IBD population. All inactivated vaccines are safe regardless of degree of immunosuppression. And we should use caution with live vaccinations. And this will be based mainly on the type, duration, and need for that specific vaccination. And early vaccination is key. In addition to susceptibility to infectious diseases, patients with inflammatory bowel disease also have higher incidences of several comorbid conditions compared to the general population. And this warrants special considerations in regard to screening. And we'll review all of these screening modalities here for colorectal cancer, cervical cancer, depression, anxiety, skin cancers, osteoporosis, effects on the eyes, as well as smoking cessation. For colorectal cancer screening, there's an increased risk of colorectal cancer, and this is based on the not only duration, but the extent of someone's disease, where they have limited or pancolonic disease. Earlier disease or stricturing disease confers higher risks. If we have concomitant primary sclerosing cholangitis, any history of dysplasia, or family history of colorectal cancer, all of these are factors which increase the risks within this population. Screening starts at 8 years following symptom onset in IBD. So if we have a pediatric patient, many of them start their colon cancer screening at extremely early ages. That'll occur sooner if patients have PSC or family histories of colorectal cancer. And then we can use average risk screening for proctitis patients only. Once we start at the 8-year mark following their initial diagnosis, surveillance intervals occur every 1 to 3 years. Specifically in ulcerative colitis, screening again starts 8 years after the diagnosis, with exception for proctitis. If you have ulcerative colitis and PSC, the primary sclerosing cholangitis, screening starts at diagnosis and surveillance then occurs annually. Surveillance colonoscopies are performed at 1 to 3 year intervals, and that, of course, is based upon the combined factors that we just went over. Importantly here, any fecal DNA testing or CT colonography are not recommended for screening or surveillance of UC-associated cancers because of insufficient evidence. So the standard of care still is colonoscopy with biopsies. All women on immunosuppressive therapy require more diligence in regard to cervical cancer screening. Women on these therapies have increased risk of dysplasia and cancer. This is associated with their IBD diagnosis, their immunocompromised state, as well as smoking status. Currently, the ACOG, CDC, and the American College of Gastroenterology all recommend annual cervical cancer screening for IBD patients, or for our females with IBD. Given the chronicity of this disease, as well as a lot of the impact it has on our bodies and our lives, there's a significant increase in depression and anxiety within the IBD population. And this is actually independent of their disease activity. You don't have to have bad disease in order to be at risk for increased depression and anxiety. Depression actually predicts lower remission rates or lower rates to relapse, quicker rates to relapse, reduce compliance with medications, and increase healthcare costs. We can use some of the typical antidepressant medications for both psychological as well as somatic symptoms, and this includes medications like the SSRIs and the TCAs. Depression screening is simple. The PHQ-2 is a simple tool that you can add to any of your clinic notes. And this simple screening states, over the past 2 months, have you felt down, depressed, or hopeless? And over the past month, have you felt little interest or pleasure in doing things? And if patients come back positive for these, we should either start to consider therapy or reach out to their primary to see who will initiate therapy here. All IBD patients should receive screening for melanoma as well as non-melanoma skin cancers. There's approximately 30% increase in the IBD population compared to the general population for melanoma, and this is independent of their biologic use. IBD patients on immunomodulators like azathioprine, mercaptopurine should receive screening for non-melanoma skin cancers as well. This is a treatment-specific risk to thiopurines. This is duration dependent. And anti-TNF therapy has also been associated with an increased risk of non-melanoma skin cancers. We can always offer sun protection and of course dermatologic surveillance with our dermatologist. There are a lot of retrospective and prospective trials, which of course help us determine a lot of the risks of some of the medications that patients are treated with. The Sesame Registry is a French registry, and it encompasses about 19,500 IBD patients. And they found that the risks of non-melanoma skin cancers are increased in thiopurines. The hazard rate for ongoing treatment is 5.9 to baseline. Hazard risk for any previous treatment, even if that treatment has stopped, is 4.1. And the hazard risk for all of the treatments is 1. So any patients that we're starting on thiopurines, we should always keep the skin cancer concerns in mind, especially if we're talking about a younger patient. Also, not all bad news about thiopurines. We use thiopurines quite a bit. In regard to colorectal cancer in the United States is the 3rd most common cancer with the 3rd most common cancer-related deaths. But patients with extensive colitis on thiopurines actually had a reduced risk of developing advanced colorectal neoplasms. The TREAT registry is one of the largest prospective cohort studies that's addressed the safety of medical therapies in Crohn's disease. And what they found was that the things that actually lead to increased risk of malignancy were age, so basically the duration of disease, for young age, duration of disease, and smoking, which is a modifiable factor, which we should all be able to address with our patients. The same registry found no increase in independent risks with immunosuppressants, anti-TNF or biologic therapies, or combinations of the two. There were some small numerical increases, however, these were not statistically significant. Crohn's disease patients should be counseled to quit smoking. This is associated with not only disease development, but also progression. It leads to poor surgical and medical outcomes, and cessation of smoking reduces the risks of flare and the need for escalation of therapy. And actually, once patients stop smoking, they can return back to a similar risk as a non-smoker IBD patient. When counseling for smoking cessation, we should be using a multidisciplinary approach. Here, we should be seeking out counseling, nicotine replacement, as well as medications. Some of the medications we use are things like bupropion or variant cycling. These studies that suggest these 2 medications are for the general population, not a specific IBD population. But again, this is an issue that all patients, these medications should be used for all patients in smoking cessation. Osteoporosis is another issue for patients with inflammatory bowel disease. The prevalence of osteoporosis and IBD is approximately from 14 to 42%. Patients have conventional risk factors. The conventional risk factors include glucocorticoid use, and this is deemed anything longer than 3 months or at greater than 7.5 milligrams per day use of prednisone. And this contributes to both osteoblast apoptosis and osteoclast activation. IBD-specific risk factors include the chronic inflammatory state with pro-inflammatory cytokines, both calcium and vitamin D deficiencies, as well as malnutrition. So all IBD patients with conventional risk factors should be screened with the bone marrow density at diagnosis and then monitored appropriately. Ophthalmology screening is also recommended for IBD population. Approximately 10 to 43% of IBD patients are affected with ophthalmological disturbances. This is one of the main extraintestinal manifestations that we see. Uveitis, episcleritis, and keratopathy are things that we're concerned with. So any sort of painful red eye needs to be evaluated immediately. We also have side effects from steroids. Steroids over time can lead to formation of cataracts or worsening glaucoma. And so at this time, we recommend annual ophthalmology evaluation. Now, this is a simple health maintenance chart. This is provided by the Crohn's and Colitis Foundation. What I like about this health maintenance chart is if your primary care and your gastroenterologist do not participate in the same EMR, this is a nice simple sheet that can be filled out in clinic. We can give this to patients so patients know exactly what they're vaccinated for, what preventative care measures they need, and then they can take this to their other doctors and have other doctors fill this in as appropriate. But I find charts like these very, very simple to add to your medical record. but also to help empower patients and take some control in ensuring that we're having appropriate communication and administration of their preventative care services. Our final thoughts, communication, of course, is key. It's very important to identify the role of all providers within the multidisciplinary care approach to the IBD patient. The gastroenterologist should be identifying all the special needs, specifically since they are the ones governing the immunosuppressive medications. And it's very important to outline the plan for therapy, and that's going to be whether we use immunomodulators, biologics, or advanced therapies. Multidisciplinary care is pivotal, and a multidisciplinary team looks like having a primary care provider, a dermatologist, an OBGYN for females, possibly psychiatry or counseling, endocrinology, rheumatology, gastroenterology, and a colorectal surgeon. Thank you.
Thank you, Dr. Aguirre. We always appreciate your knowledge and wisdom and experience at the foundation, and we thank you for coming here today. My name is Carrie Clifford, and I'm with the Crohn's and Colitis Foundation Southern Texas chapter. We are a nonprofit, volunteer-fueled organization dedicated to finding cures for Crohn's disease and ulcerative colitis and improving the quality of life of children and adults affected by the disease. Since our founding in 1967, the foundation has played a role in every major breakthrough in IBD research. We have invested more than $400 million into finding the causes, treatment, and cures for Crohn's disease and UC, and we won't stop until we've realized our vision of a future-free Crohn's and colitis. Crohn's and Colitis Foundation is dedicated to accelerating research and seeing the results through from the discovery to patient care. As part of our drive to push the boundaries of inflammatory bowel disease research, we publish our Challenges in IBD Research report to update the foundation's research agenda and identifying new research priorities. We are currently undergoing the extensive development process of our 2024 Challenges in IBD Research and plan to publish it in mid-2020. At the My IBD Learning portion of our website, we have an extensive amount of patient resources and for practitioners. On the pediatric side, we have guides for kids and teens, IBD and me activity books, guides for parents, teachers, how to swallow pills, pediatric transition, and so much more. The brochures are free, and you can just go on the website and order them for your practice, and you can hand them out. And typical things that teens go through, like school accommodations, which is a huge one. We actually have on the website pre-made letters that they can just kind of modify. And that's a big deal because they miss a lot of school. And so we have letters that are already made out that they can modify for that. Dating, stress, and the pediatric transition, which is a big deal, going from having your parents take care of your health to you taking care of your own health. Campus Connect is another part of the website. That equips students with the knowledge, skills, and tools necessary to effectively manage their IBD in college. Tips for adjusting to the new normal that they have. So, you know, you go off to college and you have to find new friends and you have the whole college experience being independent, missing your family. But on top of that, IBD patients have to find new doctors. They have to learn to manage the insurance companies, sharing their diagnosis with new friends. A lot of these kids go off and all their friends know about their disease, and now they have to meet new people and explain their disease. So there's a lot of resources on the campus website. Professional education clinical hub has a lot of resources for healthcare professionals. Discover up-to-date educational resources to enhance your knowledge of Crohn's disease and UC on the IBD clinical hub. The content covers diagnosis, treatment, management. We have free resources to equip your practice and empower your patients. The foundation has journals, publications created for healthcare professionals and the general public, offering the latest information on Crohn's disease and UC. IBD Circle is an online community exclusively for professional members of the Crohn's and Colitis Foundation, and the ACG, offering professional advice, collaboration support, and practice resources. Nutritional resources, a collection of educational material for medical professionals to address malnutrition and IBD and support nutritional therapy goals. Professional conferences and events, opportunities for healthcare professionals to attend seminars, conferences, and events nationwide, enhancing their knowledge of IBD, fostering networking. Visiting IBD Clinical Fellows Program, a competitive program allowing qualified gastroenterology fellows to observe and gain experience in treating and managing IBD patients. Advanced IBD Fellowship Curriculum, developed by the American College of Gastroenterology and the Crohn's and Colitis Foundation. This curriculum defines professional activities for advancement of IBD fellows during their fellowship year. We have a biosimilars video training series, a new 4-module video training for advanced practice providers to impart the safety and efficacy of biosimilars and share best practices for explaining the potential benefits to their patients. We have a referral career pathways IBD journal. And then on our local chapter here in Southern Texas, we have quarterly mix and sips, which is a great way if you're interested in IBD and learning more about it. We have every quarter we have a mix and sip. It's very casual. It's at somebody's house, and you'll be able to meet healthcare providers, families, patients, and anyone involved in our community. We also have our Take Steps Walk, which Dr. Span and the College of Medicine is going to be our on-campus sponsor for next year. It'll be on April 26th. And we welcome anyone who wants to participate in that as well. Thank you for taking the time.
Do we have any questions for our guest today?
Please use your mic. There's a, that's.
In the high-dose live varicella-zoster vaccine came out, it was not approved before age 60, as I recall, because I waited until 2 days after my birthday to get it. Do you have problems with reimbursement when you use try to use it in younger patients?
Absolutely. That's insurance is always a challenge. And getting things like Shingrix is always difficult before the age of 50. The Crohn's and Colitis Foundation also has a lot of letters, but I've also just generated many letters that insurances have not said no to when we've outlined why the patient's at a higher risk. And then it's also in some of our also some of our guidelines as well. And so I reference the guidelines whenever I have to write a letter to the insurance. So that can be a challenge. But there's almost nothing we do any longer where the insurances give us problems. But we are pretty successful whenever we do have a legitimate reason to start it.
Great to hear that. One more question. On the treatment of depression, you have SSRIs and tricyclics.
Yes.
I assume there's not a contraindication to desvenlafaxine, a dual reuptake inhibitor.
So when I mentioned SSRIs versus the TCAs, a lot of times gastroenterologists use TCAs more frequently for the somatic symptoms of irritable bowel or functional GI disorders on top of their IBD. If they don't have many of those somatic complaints, then I'd probably initially start with an SSRI.
There a contraindication to desvenlafaxine.
Which is the dual. Honestly, I'd have to go back and read. I'm not too sure about that one.
Thank you.
Yes, sir.
Ryan?
Dr. Aguirre, thank you so much for your time today. I had two questions, both clinical. First question, going back to one of the first slides. In clinical practice, is there typically a pattern of specific white blood cell inflammation or elevation that you see supporting IBD, like for example, elevated eosinophils relative to others, or is this still mostly a clinical diagnosis?
Yeah, so currently right now, it's still a clinical and pathologic diagnosis. We don't quite have as we move forward in more research, we're starting to hone in more on which specific inflammatory pathways are affecting certain patients, so we can start to target those patterns, so to speak, with more specific or individualized medicine. But currently, if we had we would be combining a clinical presentation with serologic inflammatory markers and then a tissue diagnosis from an endoscopy to confirm the diagnosis.
Thank you. Follow-up question to that. Is it currently thought that the same inflammatory pathway leading to inflammatory bowel disease could provide the same jumping off point for all of these observable elevated risk with different cancers?
Sure. So the challenge there is there are multiple pathways which feed into the inflammatory milieu in IBD. And there are subsets across the world which have genetics that make them susceptible, and then other populations that don't have those same genetics and still develop the same disease. Another theory that that we deal with is when we start a patient on a specific, let's say an anti-TNF therapy. Over time, there's a theory that the immune system can actually start to adapt to the initial anti-TNF blockade and reroute its inflammatory processes to another pathway like an IL-12 or IL-23. And that's many times when we're switching medications. As we move forward, though, I really do hope that we have testing that will help us determine from the get-go which medication would be targeting that specific patient's inflammatory patterns.
Good afternoon. Thank you both for the presentation. I have a question. Early on, you mentioned that these patients with IBDs have limited access to preventative health, or they have lower rates of preventative. Can you explain a little bit as to why that is, maybe for both of you? Is it just a broad understanding of why that is?
Oh, and this is a question I ask quite a bit. For a lot of the other populations, for instance, COPD or heart failure, it's quite, or kidney disease, it's quite obvious that these are high-risk populations which require more diligent preventative care. The IBD patient fits all of those markers for having a chronic debilitating condition and a dysregulated immune response. I think partly it's gonna be education. As I mentioned, the survey showed that gastroenterologists say like, oh, this is somebody else's job, and then the other side says, no, that's their job. And so when you have that wide of a divide, and then you even have gastroenterologists who are not administering things correctly, at least within that survey, it shows that there's an education issue and then there's also a communication issue. So I think that those two are probably key to and why I think talks like this are important. You have anything to add, Karen?
Well, it's on. From my own personal experience, I had a lot of unusual, at least I thought unusual symptoms. You know, some of them GI, but also my joints ached, my hair was falling out, my eyelashes were even falling out. And it took more than 10 years for somebody to finally discover that it was in fact Crohn's. In fact, I found out 2 months after I started working for the foundation that I had Crohn's. So I think education is a big part of it, and doctors kind of, because there's so many different autoimmune disorders. In fact, my PCP is the one who really stuck with it. I had my inflammation markers were elevated, but they were before, but she really took the time to find out what it was, and she was going to send me to a rheumatologist, and she said, well, you know, you're in line or you're due for a baseline colonoscopy. And so that's how we discovered it. She was going to send me to a rheumatologist because my joints were aching and all of that. So I think just kind of sticking with it and making sure we find out what's causing all the issues.
Mm-hmm. Yes, ma'am.
For tuberculosis screening, is there a preferred method that is like more accurate or better for even people who aren't on immunosuppressive therapy yet?
Sure. We primarily use quantiferin testing for TB. And if you didn't, most insurances would give you a big pushback if you didn't have quantiferin testing done. I don't think I've ever had. Yeah, I don't think I've ever even tried to to go X-ray and screening with the skin test. Any questions from the chat?
Thank you so much for your expertise, and we're really grateful for your presentation.